LYNPARZA is indicated in combination with bevacizumab for the maintenance treatment of adult patients with advanced epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to first-line platinum-based chemotherapy and whose cancer is associated with homologous recombination deficiency HRD-positive status, defined by either a deleterious or suspected deleterious BRCA mutation and/or genomic instability. Select patients for therapy based on an FDA-approved companion diagnostic for LYNPARZA. Select safety information. Serious and potentially fatal adverse events included myelodysplastic syndrome, acute myeloid leukemia, MDS-AML. Monitor patients for hematological toxicity at baseline and monthly thereafter. Discontinue if MDS-AML is confirmed. Pneumonitis. Interrupt treatment if pneumonitis is suspected. Discontinue if pneumonitis is confirmed. Venous thromboembolism, VTE, including severe or fatal pulmonary embolism, PE. Monitor patients for signs and symptoms of venous thrombosis and PE, and treat as medically appropriate. Hepatotoxicity, including drug-induced liver injury, DILI. Evaluate bilirubin and transaminases at baseline and throughout treatment with LYNPARZA. For patients who develop abnormal liver tests after LYNPARZA, monitor more frequently for liver test abnormalities and clinical signs and symptoms of hepatic toxicity. If DILI is suspected, interrupt LYNPARZA. If DILI is confirmed, discontinue treatment. Advise patients of the potential risk of embryo-fetal toxicity and to use effective contraception. Most common adverse reactions, greater than or equal to 10% in clinical trials, in combination with bevacizumab, were nausea, fatigue, including asthenia, anemia, lymphopenia, vomiting, diarrhea, neutropenia, leukopenia, urinary tract infection, and headache. Please see important safety information later in this video.
Hello, I'm Dr. Sharyn Lewin, Director of Gynecologic Oncology at Holy Name in Teaneck, New Jersey. I'm also an assistant clinical professor in the Icahn School of Medicine at Mount Sinai Hospital, New York, New York. During the time that we're together today, we will review the primary analysis from the PAOLA-1 trial, data from the 5-year follow-up overall survival analysis, as well as a post-hoc exploratory subgroup analysis of PFS by higher and lower clinical risk in HRD-positive patients. PAOLA-1 was a registration trial that was designed to meet an important unmet need. Key eligibility criteria included women with stage 3 or 4 advanced ovarian, primary peritoneal, or fallopian tube cancers, regardless of BRCA mutation status, so really all comers were enrolled. Women could have had either upfront surgery followed by adjuvant chemotherapy or neoadjuvant chemotherapy followed by an interval surgery. They had to have at least 3 cycles of bevacizumab in combination with platinum-based chemotherapy. If they had at least a partial response, they were then randomized in a 2-to-1 fashion to maintenance therapy with either bevacizumab in combination with LYNPARZA or bevacizumab alone. So, this trial, unlike the other PARP trials in ovarian cancer, has an active comparator arm, bevacizumab, which was continued for up to 15 months. This included the time given with chemotherapy and as maintenance at the standard dose of 15 milligrams per kilogram. In the experimental arm, LYNPARZA was given at 300 milligrams twice a day for up to 2 years or until disease progression or unacceptable toxicity. The primary endpoint was investigator-assessed progression-free survival. Overall survival was a key secondary endpoint, and a pre-specified exploratory analysis looked at PFS in predefined subgroups, including those with HRD and BRCA mutation status. PFS in HRD-positive patients served as the basis for the FDA-approved indication. We saw in the PAOLA-1 trial that about half of the participants had HRD, so essentially the biomarker status that we saw in PAOLA-1 really mirrors what we see in real-world practice. HRD was measured by a companion diagnostic, Myriad's MyChoice CDx. Their genomic instability score measures loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. Now, let's look at the initial data from the primary analysis before we talk about the pre-specified 5-year follow-up in the HRD-positive patients. As you can see from the top line in green, the median PFS with the combination of LYNPARZA plus bevacizumab in the primary analysis was 37.2 months versus 17.7 months with bevacizumab alone. Here, the hazard ratio was 0.33, so a 67% reduction in progression or death by having a combination of LYNPARZA plus bevacizumab versus bevacizumab alone. Here, you can see the Kaplan-Meier curve from the 5-year follow-up data in these HRD-positive patients. The median PFS with the combination of LYNPARZA plus bevacizumab was 46.8 months, or almost 4 years compared to the bevacizumab-only arm, in which the median PFS was 17.6 months, or almost 1.5 years. Here, the hazard ratio was 0.41, so essentially a 59% risk reduction in progression or death by having LYNPARZA plus bevacizumab versus bevacizumab alone. At 5 years, approximately half of those women with HRD were progression-free with the combination of LYNPARZA plus bevacizumab versus only approximately 19% with bevacizumab alone. Data were not powered to detect a statistical difference. Next, let's look at the overall survival data in these patients. In the pre-specified 5-year follow-up overall survival analysis in HRD-positive patients, at 5 years, nearly 66% of patients were estimated to be alive with a combination of LYNPARZA plus bevacizumab versus only about 48% with bevacizumab alone. You can see here the median overall survival with the combination was 75.2 months, or about 6.3 years, and in the bevacizumab-only arm, this was 57.3 months, or about 4.8 years. Of note, this analysis was not powered to detect a statistical difference. This is a post-hoc exploratory subgroup analysis of progression-free survival by clinical risk for relapse in HRD-positive patients. These are women with stage 3 disease who had upfront surgery and had residual disease, or received neoadjuvant chemotherapy, or stage 4 patients. There is no official clinical consensus on what is considered higher versus lower risk. Data are based on post-hoc exploratory subgroup analyses in 2 clinical subgroups, higher risk and lower risk, including biomarker status. Neither HRD status nor risk factor was a stratification factor in PAOLA-1. The lower risk patients are those with stage 3 disease that underwent upfront surgery and were completely resected. Those women, as we know, fall into a sort of better prognostic group than the highest risk patients. The median PFS in the LYNPARZA plus bevacizumab arm has not yet been reached, and if you look at the Kaplan-Meier curve, LYNPARZA plus bevacizumab at the 2-year mark, 90% of the lower risk patients were progression-free at 2 years. Whereas with bevacizumab alone, the median PFS here is 22 months and only 43% of patients are progression-free at the 24-month mark. So there was a hazard ratio of 0.15, an 85% risk reduction in progression or death by having the combination of LYNPARZA plus bevacizumab versus bevacizumab alone. The median PFS in these highest risk patients was about 36 months with a combination of LYNPARZA plus bevacizumab versus about 16 months in the group that was treated with bevacizumab alone. Here, the hazard ratio was 0.39, almost a 61% risk reduction in progression or death by having the combination of LYNPARZA plus bevacizumab versus bevacizumab alone. Here are the data for the 5-year follow-up post-hoc exploratory subgroup analysis of overall survival by clinical risk for relapse in HRD-positive patients. Again, there is no official clinical consensus on what is considered higher versus lower risk, and neither HRD status nor risk factor was a stratification factor in PAOLA-1. The median OS in the LYNPARZA plus bevacizumab arm and the bevacizumab alone arm are not evaluable, with a hazard ratio of 0.31, so a nearly 70% risk reduction. Looking at the 5-year mark, 88.3% of patients were estimated to be alive with LYNPARZA plus bevacizumab, and 61.3% were estimated to be alive with bevacizumab alone. You can see that the median OS in these higher risk patients was 67 months with the combination of LYNPARZA plus bevacizumab versus 54 months with bevacizumab alone. The median for LYNPARZA plus bevacizumab is unstable due to a lack of events. Here, the hazard ratio was 0.70, so about a 30% risk reduction with the combination of LYNPARZA plus bevacizumab versus bevacizumab alone. Here we have the adverse reactions reported in 10% or more of women with LYNPARZA and bevacizumab, and 5% or more in those that received bevacizumab alone. So, as you can see, most of the adverse reactions were grade 1 and grade 2. Adverse events that we would typically think about, like fatigue, nausea, anemia, and some of the GI side effects, were more common. Fatal adverse reactions occurred in one patient due to concurrent pneumonia and aplastic anemia. Serious adverse reactions occurred in 31% of patients who received LYNPARZA plus bevacizumab. Serious adverse reactions in greater than 5% of patients included hypertension and anemia. In addition, venous thromboembolism occurred more commonly in patients receiving LYNPARZA plus bevacizumab than in those receiving placebo plus bevacizumab. This screen shows the laboratory abnormalities that were reported in 25% or more of patients treated on this study. Laboratory abnormalities were also mostly grade 1 and grade 2. Grades 3 or 4 lab abnormalities were experienced by 13% of patients in the active treatment arm and 4% in the active comparator arm. The most common laboratory abnormalities were decrease in hemoglobin, decrease in lymphocytes, increase in serum creatinine. You can see that in the LYNPARZA plus bevacizumab arm, 54% of patients needed dose interruptions, 41% had dose reductions, and 20% discontinued due to adverse reactions. Overall, the combination of LYNPARZA plus bevacizumab was well tolerated, so the median duration of treatment with LYNPARZA was a little over 17 months and 11 months for bevacizumab post-randomization, and anemia, nausea were reported to cause discontinuation rates in 4% and 3% of patients respectively. In the placebo arm plus bevacizumab, you can see dose interruptions were necessary in about 24%, dose reductions in about 7%, and discontinuations in about 6%. Here we see the adverse events of special interest, and it's good to know that at the 5-year follow-up analysis, no new safety signals were identified. At the 5-year follow-up analysis, the incidence of MDS-AML in patients with HRD-positive status was 1.6% in the LYNPARZA plus bevacizumab arm and 2.3% in the bevacizumab plus placebo arm. When we're looking at primary malignancies, the rate of primary malignancies in the combination group was about 4% in the 5-year follow-up analysis and about 3% in the bevacizumab-only group. And the risk of pneumonitis in the combination group was about 1.3% at the 5-year analysis and under 1% in the bevacizumab-only group. Overall, the safety profile remained consistent with the primary analysis. The National Comprehensive Cancer Network, or NCCN, recommends the use of olaparib or LYNPARZA plus bevacizumab as a maintenance option for patients with a BRCA mutation or who are HRD positive and who achieve a complete or partial response after first-line platinum-based chemotherapy plus bevacizumab. This is a Category 1 recommendation. PAOLA-1 shows the efficacy of using bevacizumab and LYNPARZA as maintenance therapy in HRD-positive advanced ovarian cancer after response to platinum-based chemotherapy in combination with bevacizumab. In the pre-specified exploratory analysis, the median PFS with LYNPARZA plus bevacizumab was about 3.1 years and 1.5 years in the bevacizumab-only arm. In the pre-specified follow-up analysis at 5 years, approximately half of patients, 46%, were progression-free with LYNPARZA plus bevacizumab, and 19% were progression-free with bevacizumab alone. So, there was an improvement in the median progression-free survival for these women with HRD when you're adding LYNPARZA to bevacizumab in the maintenance setting. The median overall survival with the combination was 75.2 months, or about 6.3 years, and in the bevacizumab-only arm, this was 57.3 months, or about 4.8 years. The most common adverse reactions, grade 1 and grade 2, included fatigue, anemia, nausea, vomiting, lymphopenia, and leukopenia. PAOLA-1 treatment eligibility is driven by HRD status. About half of women with ovarian cancer have HRD or HRD-positive tumors. It's really critically important that we not only do germline testing right when these women are diagnosed with ovarian cancer, but also HRD testing so we can make important treatment decisions in the maintenance setting. Next, we will review the important safety information for LYNPARZA.
Important safety information. Contraindications. There are no contraindications for LYNPARZA. Warnings and precautions. Myelodysplastic syndrome, acute myeloid leukemia, MDS-AML, occurred in approximately 1.2% of patients, 26 of 2,219, with various BRCAM, GBRCAM, HRR gene-mutated or HRD-positive cancers who received LYNPARZA in clinical studies as a single agent or as part of a combination regimen, consistent with the approved indications, and the majority of events had a fatal outcome. The median duration of therapy in patients who developed MDS-AML was approximately 2 years, range less than 6 months to greater than 4 years. All of these patients had previous chemotherapy with platinum agents and/or other DNA-damaging agents, including radiotherapy. In SOLO-1, patients with newly diagnosed advanced BRCAM ovarian cancer, the incidence of MDS-AML was 1.9%, 5 of 260 in patients who received LYNPARZA, and 0.8%, 1 of 130, in patients who received placebo based on an updated analysis. In PAOLA-1, of patients with newly diagnosed advanced ovarian cancer with HRD-positive status, the incidence of MDS-AML was 1.6%, 4 of 255, in patients who received LYNPARZA, and 2.3%, 3 of 131 in the control arm. In SOLO-2, patients with BRCAM platinum-sensitive relapsed ovarian cancer, the incidence of MDS-AML was 8%, 15 of 195, in patients who received LYNPARZA, and 4%, 4 of 99, in patients who received placebo. The duration of LYNPARZA treatment prior to the diagnosis of MDS-AML ranged from 0.6 years to 4.5 years. Do not start LYNPARZA until patients have recovered from hematological toxicity caused by previous chemotherapy, less than or equal to grade 1. Monitor complete blood count for cytopenia at baseline and monthly thereafter for clinically significant changes during treatment. For prolonged hematological toxicities, interrupt LYNPARZA and monitor blood counts weekly until recovery. If the levels have not recovered to grade 1 or less after 4 weeks, refer the patient to a hematologist for further investigations, including bone marrow analysis and blood sample for cytogenetics. Discontinue LYNPARZA if MDS-AML is confirmed. Pneumonitis, including severe and fatal cases, has occurred in patients treated with LYNPARZA. In clinical studies, among patients who received LYNPARZA as a single agent or as part of a combination regimen, the incidence of pneumonitis, including fatal cases, was 1.0%, 29 of 2,851. If patients present with new or worsening respiratory symptoms such as dyspnea, cough, and fever, or a radiological abnormality occurs, interrupt LYNPARZA treatment and promptly assess the source of the symptoms. If pneumonitis is confirmed, discontinue LYNPARZA treatment and treat the patient appropriately. Venous thromboembolism, VTE, including severe or fatal pulmonary embolism, PE, occurred in patients treated with LYNPARZA. Monitor patients for signs and symptoms of venous thrombosis and pulmonary embolism and treat as medically appropriate, which may include long-term anticoagulation as clinically indicated. Hepatotoxicity, including drug-induced liver injury, DILI. Hepatotoxicity, including severe and potentially fatal cases of DILI, has occurred in patients treated with LYNPARZA. Evaluate bilirubin and transaminases at baseline and throughout treatment with LYNPARZA. For patients who develop abnormal liver tests after LYNPARZA, monitor more frequently for liver test abnormalities and clinical signs and symptoms of hepatic toxicity. If DILI is suspected, withhold LYNPARZA. Upon confirmation of DILI, discontinue LYNPARZA. Embryo-fetal toxicity. Based on its mechanism of action and findings in animals, LYNPARZA can cause fetal harm. Verify pregnancy status in females of reproductive potential prior to initiating treatment. Females. Advise females of reproductive potential of the potential risk to a fetus and to use effective contraception during treatment and for 6 months following the last dose. Adverse reactions. First-line maintenance advanced ovarian cancer in combination with bevacizumab. Most common adverse reactions, grades 1 through 4, in greater than or equal to 10% of patients treated with LYNPARZA bevacizumab, and at a greater than or equal to 5% frequency compared to placebo bevacizumab in the first-line maintenance setting for PAOLA-1 were nausea 53%, fatigue including asthenia 53%, anemia 41%, lymphopenia 24%, vomiting 22%, and leukopenia 18%. In addition, the most common adverse reactions, greater than or equal to 10% for patients receiving LYNPARZA bevacizumab, irrespective of the frequency compared with the placebo bevacizumab arm, were diarrhea 18%, neutropenia 18%, urinary tract infection 15%, and headache 14%. In addition, venous thromboembolism occurred more commonly in patients receiving LYNPARZA bevacizumab 5% than in those receiving placebo bevacizumab 1.9%. Most common laboratory abnormalities, grades 1 through 4, in greater than or equal to 25% of patients for LYNPARZA in combination with bevacizumab in the first-line maintenance setting for PAOLA-1 were decrease in hemoglobin 79%, decrease in lymphocytes 63%, increase in serum creatinine 61%, decrease in leukocytes 59%, decrease in absolute neutrophil count 35%, and decrease in platelets 35%. Drug interactions. Anti-cancer agents. Clinical studies of LYNPARZA with other myelosuppressive anti-cancer agents, including DNA-damaging agents, indicate a potentiation and prolongation of myelosuppressive toxicity. CYP3A inhibitors. Avoid co-administration of strong or moderate CYP3A inhibitors when using LYNPARZA. If a strong or moderate CYP3A inhibitor must be co-administered, reduce the dose of LYNPARZA. Advise patients to avoid grapefruit, grapefruit juice, Seville oranges, and Seville orange juice during LYNPARZA treatment. CYP3A inducers. Avoid co-administration of strong or moderate CYP3A inducers when using LYNPARZA. Use in specific populations. Lactation. No data are available regarding the presence of olaparib in human milk, its effects on the breastfed infant, or on milk production. Because of the potential for serious adverse reactions in the breastfed infant, advise a lactating woman not to breastfeed during treatment with LYNPARZA and for 1 month after receiving the final dose. Pediatric use. The safety and efficacy of LYNPARZA have not been established in pediatric patients. Hepatic impairment. No adjustment to the starting dose is required in patients with mild or moderate hepatic impairment. Child-Pugh classification A and B. There are no data in patients with severe hepatic impairment. Child-Pugh classification C. Renal impairment. No dosage modification is recommended in patients with mild renal impairment. CLCR 51 through 80 milliliters per minute estimated by Cockcroft-Gault. In patients with moderate renal impairment, CLCR 31 to 50 milliliters per minute, reduce the dose of LYNPARZA to 200 milligrams twice daily. There are no data in patients with severe renal impairment or end-stage renal disease. CLCR less than or equal to 30 milliliters per minute. Please see complete prescribing information, including medication guide, at the URL shown on the screen. You are encouraged to report side effects related to AstraZeneca products by calling 1-800-236-9933. If you prefer to report these to the FDA, please call 1-800-FDA-1088.
Thank you for your time. I hope you found the information presented to be useful to your clinical practice.